Next up is HITLAB's own Director of Medical Affairs, Dr. Prem Sreenivasan, and he will be leading an interview today with a group, two individuals who are working very diligently in the areas of mental health. I'll let Prem, if you could do the introductions. Thank you, Prem, for leading this one.
Yeah, thanks, Stan. Delightful, great, terrific session, and congratulations for this timely series of talks on the space as we go through this information-packed day. Today, I'm very happy to introduce Dr. Daniel Barron and Dr. Michael Arato, who are in the mental health space. And these are two exceptional leaders, and please join me in welcoming them. And perhaps we can start with a brief introduction by Dr. Arato.
Yeah, hi, thanks. So glad for everyone to be here. Thanks for your attention. So I'm the Chief Medical Officer and co-founder of Ellipsis Health. And my background is about 30 years as a board-certified emergency physician, and I still practice. And I've also been the Chief Medical Information Officer of a integrated hospital and clinic system for about 15 years, where I led innovation there. I actually worked with startups, and I implemented 3 different EHRs. And I've also been a digital health advisor and investor. So great to be here.
So terrific, and welcome. As we get started with this session here, I'd like to start with you in terms of some of the learnings that you've had in the recent 18-20 months that the global pandemic, and some of the important lessons that you have learned in this space. I'm sure the audience will be very interested in learning about it.
Yeah, in terms of what we've learned about the global pandemic, well, I think it's just sort of specifically, and I'm going to speak from sort of the bias of mental health here. It really is focused on the fact that there was an epidemic of mental health issues, specifically mostly depression and anxiety beforehand. And now that sort of has been brought to light and exacerbated because of COVID. And so, with people not being able to socialize, having to shelter in place, and then have all these restrictions placed on them. I mean, we're essentially a social animal, and this has really affected us significantly. And we already had this problem with supply and demand in terms of mental health providers, and it's just widened that gap significantly. Luckily, and I think the silver lining with the pandemic is that it pushed telehealth right to the forefront. And the way that telehealth has been around for decades, but it needed that push, that essentially the economic push of establishing reimbursement and removing a lot of the restrictions for it to really take hold. And the fact that it's taken hold so significantly, and still, I think we're never going to go back to the same norm again. I think that's because this is something that really works. And I think, we're seeing the transition from medicine being obviously, paternalistic and everything, to moving more towards patient-centric, and therefore patient convenience, and moving towards, the patient and taking care of the patient where the patient is, and not where necessarily the provider is, because it doesn't have to be that way all the time.
It's terrific. Every time we look at the advances in the past 20 months or so, the mental health space has been at the top of the list. So we'd be delighted to learn about some of the key areas that you feel will continue to progress as we go through this, as we transition out of the pandemic.
Yeah. So, I mean, I think what you're seeing now is, with mental health specifically, you're seeing new models of care being created in an answer to that supply and demand gap that we have. where we don't have enough providers. You're seeing a lot of service, startup companies coming in and providing a service for them. But what's interesting is they're providing a tiered type of service. So you're starting off with people, instead of us always having to see a PsyD, a psychologist, or a licensed provider, you're seeing a lot of these startups use unlicensed people who have been trained to a certain extent to provide some care. And sometimes that's what you need in the step care model, right? You start off with someone who may not need as much intensive care, maybe not by a licensed provider, but maybe by just someone to lend an ear to how their problems. And there's a lot of demand for that too. There's a lot of loneliness in our society right now. So so you're seeing the rise of this type of care model where you start off with an unlicensed person, and then depending on your condition, et cetera, then you can bring in further licensed people on higher and higher levels of care.
So thank you, Michael, for that. And please join me also in welcoming Dr. Daniel Barron, who had a few minutes, who just joined us. Terrific, Daniel, for you to take time to connect and to be part of this impressive panel. So as we get started here, would you please take a couple minutes to take us through your journey, to take us through a series of brief introductions to present to the audience some of your efforts and some of your learnings.
Thanks. So I appreciate the opportunity to speak here, and I apologize for running a little late. I put in the chat that there's a little jackhammering going on outside of my office, so I figured this would be a better option, a little quieter. And so the way that I became interested in digital health space was both by my clinical work and observations, and further by my research using fMRI and brain imaging methods. And so I observed that a lot of what I was doing, both in the clinic and in my research lab, they weren't the same levels of precision. Right? And so in an fMRI study, we use MRI scanners, which are carefully calibrated so as to be able to collect very precise data to measure the signal of interest. And yet, both in the clinic and when we're talking about symptoms or diagnosis, we ask patients to tell us about their symptoms, and then we, might rate them from 0 to 10 in terms of severity, but we don't actually measure the data points that we're interested in. For example, speech or facial expression, or even activity or social connectedness, all these things are clinically relevant. Yet we don't have the tools, we're not using the tools right now to be able to measure and then quantify them with precision. So that's how I became interested. And throughout residency, I was writing for Scientific American kind of as a hobby. And I had the opportunity to meet a lot of real thought leaders and forward thinkers in this space. And I wrote a series of pieces describing these innovations in digital measurement using smartphones, using smartwatches, accelerometers, et cetera. And in my last year of residency, I wrote a very short book for Columbia Global Reports called Reading Our Minds, The Rise of Big Data Psychiatry, where I kind of step readers through these different tools that are being developed that can then hopefully provide more precision to both clinical work and also to clinical research. So I think that's in a nutshell my story. Is that what you're hoping to hear, Prem?
Absolutely. So I know that you have published this book, and thank you for giving us a brief flavor of the content. The group, the audience would be delighted to hear, in a nutshell, a couple other takeaways from your book. Perhaps you can highlight some of those now, or perhaps later in the program.
Well, it turns out just this morning I had a very engaging debate with a psychiatrist and clinical researcher in Germany, Gerhard Grunder, who this was for a monk debate, which will be released as a podcast. And so we were able to touch on a lot of the topics that I discuss in my book. One of the most salient for, I believe, this audience will be what constitutes useful data and what do we do with those data once we have them. And so the point that I'm trying to make in the book is that many fields of medicine approach behavior, they approach clinical data in a way that is very different from the way we approach behavior. For example, a cardiologist who is interested in understanding the heart will, of course, discuss the patient's feelings about chest pain or whatever limitations they may have. But then physicians, by and large, agree that it's very difficult, if not impossible, to really understand the function of the heart. Right? And so we've developed instruments to help us see things that are otherwise invisible. For example, the electrocardiogram helps us see the flow of electricity through the heart's muscles. Right? And so by carefully, precisely measuring everything from heart rate to blood pressure, all the way through to specific proteins in the heart and the flow of blood through specific vessels in the heart, cardiologists feel that they can get a much more complete picture of how to be a good clinician and treat their patient. In behavior, we still, psychiatrists and even other disciplines still approach behavior in a conversational way, right? To where we ask our patients how they're feeling, and yet we don't really dig into and quantify those types of behavior which we think are relevant. And so, for example, the mental status exam is kind of the bread and butter assessment of behavioral health function, right? So speech is categorized, affect, you can describe someone's affect as flat, depressed. And so really what I'm talking about in the book is ways that we can be more precise, ways that we can bring to bear technologies that have been developed specifically to quantify and trace behavior over time. And hopefully we can gather a lot of useful information and be able to better understand and treat our patients. So I'm just looking at the comments here. Oh, it's a LinkedIn profile. Too many people are accessing the speaker's profile at the same time. Oh, well, that's great.
So I just think the content, the rich content that you both bring to the panel is going to generate a lot of interest. So trust me, you folks are going to have many comments and questions that are going to be coming through the chat. And as we turn back to Michael and Daniel, you both are practicing physicians. So Mike, I wanted to ask you, as you focus on depression and anxiety, you touched upon some of the emerging trends, but would you like to say a few words on how this relates to different age groups, how it relates to different geographies that you may have experienced?
Yeah, just like medicine is local, so is the practice and the medicine and how it's done. And obviously different parts of the country and different age groups go through different aspects of health in different ways. When it comes to depression, for example, you see a couple peaks during someone's lifetime. Initially in adolescence, when people first present with symptoms of depression, and this can be early adolescence. And unfortunately, in our country, it can take up to 11 years from the time that those symptoms first progress till they actually get treatment. But that's one peak. And then as you move in age up to, for example, when you get into college, or when you get into the workforce, there's another small peak because of and especially in anxiety as you're going into a different environment. And then there's another peak, especially when in the older population after you've retired. And we've heard of the problems with loneliness, which is a precursor to depression. And so, I mean, throughout and then depending if you're, if you're female, there's also earlier on in their life, there's the issue of postpartum depression, which is significant. And so, there's an ebb and flow of ways where the depression and anxiety, which is usually a comorbid condition in about 70% of the cases, happens through someone's life cycle. And it's important to be able to monitor that. And that's what Ellipsis Health is doing, to provide some form of objective monitoring, like Dr. Barron was talking about, which we don't have now as much in psychiatry.
Any points you wanted to add,
Yeah.
Dr. Barron, to that?
Yeah, I think one of the really the added value that quantitative measurements will offer us is to potentially reframe the way we think about depression as a category, right? And so it's well known that depression, anxiety, PTSD, stress, all of these conditions, which we have words for, are not discrete entities, right? So depression is often seen with anxiety. All of those are more common in PTSD. And me, so I'm starting an interventional pain psychiatry program here at Brigham and Women's Hospital, and all of those are more comorbid with chronic pain. And so quantitative measures has the ability to reframe these diagnostic boundaries, and in fact, perhaps even create new diagnostic tools that we can use to assess patients. So in terms of Mike's tools that he's developing, certain speech signatures, or perhaps even facial expression signatures, or expressions of movement or activity, those very well may be more useful in terms of identifying possible treatments and outcomes of treatment than traditional categories like depression or anxiety. And so both in terms of monitoring, being able to predict the subsequent need for hospitalization or just even a change in medication, I would expect and I would hope that more information, more precise information will add a lot of value to many stages in the clinical ecosystem.
So coming back to you, Mike, you have announced an app. It's Razor Hire. And would you like to add some comments towards that and add some content to that, please?
Sure. Yeah, a Rising Hire it's called. And it's an app that we use to actually quantify a voice. So again, just really quickly, voice is where psychology meets biology, right? And we're using voice as a vital sign. As Dr. Barron was saying, we need the more quantitative tools. And the voice is a real window into the mind. And what we do with Rising Hire is we give the user the chance to talk about what they're interested in talking about. And we give them several different topics. And then they choose the topic they want to talk about. And then they can choose more than one topic. They can talk for a little bit of time. And then after a few minutes of speech, we are able to provide an assessment. And this is a clinical grade assessment. So we're a clinical decision support tool. So this is a tool that actually has to be used in concert with a provider care or provider organization. And so their assessment then gets routed directly back to the provider, where the provider can, again, do for screening purposes, understand that, or as Dr. Barron was talking about, for monitoring purposes, for medication titration, et cetera. And we also have an output that can show what they're talking about so that people can actually, providers can see what is it that they're really focusing on or ruminating on. We also provide obviously longitudinal analysis so we can see how that changes over time. And so we're really excited about this because it's adding that extra objective measure to the provider's armamentarium. And we've done a lot of publishing of papers to show the accuracy of our algorithms.
That sounds terrific. So from the user standpoint, any other points you would like to make in terms of acceptance and so forth? Any insights?
Sure. Yeah, I think, yes, some interesting insights that we found out, and thanks for pointing that out, is that, for example, about 30% of patients that use this actually use it more than the prescribed amount. We usually start off with about every 4 to 7 days, but it turns out 30% use it more. And obviously there's a reason for it. They like it. And maybe, and we hypothesize right now, is that it's somewhat cathartic for them. And then in this case, therapeutic. And so that's one great insight we found out about it. And we see that the engagement is really good because rather than having to fill out a survey, which is repetitive, and which may not ask the questions that they're really focused and interested on, they get to talk about what they're really concerned about, and it really empowers the user to express where their problems are and what they want to be heard for.
Oh, that's terrific. So, I could keep you both for the next 2 hours, but my time is coming to an end. But as we come towards the end of the session, I'd like to give each of you a couple of minutes to provide some key takeaways from your own vantage point. So perhaps we could start with Dr. Barron.
Yeah, so from my vantage point, what I'm interested in is having access and develop tools that can make me effective as a clinician. And the way I see these tools being most useful is in more clearly defining the clinical problem, right? And so right now, if you look at the diagnostic criteria, and actually I just published a couple of commentaries working through the mathematics of this, there are around 7.6 trillion patterns of symptoms that can meet diagnostic criteria for schizophrenia. And there are only 488,000 combinations of symptoms, which will meet diagnostic criteria for a major depressive episode. And so what I think these quantitative tools will allow us to do is to really clean up our categories, to be able to more clearly define the clinical problems, and also to make more explicit what it is that we're targeting with treatment, and then also whether or not those targets are being met. So that's what I'm excited about overall.
That sounds terrific. And there was a remark in the chat box on the title of your book. So perhaps you want to just mention
Sure,
it.
I'll include the link. Yeah.
Yeah.
The name of the book is Reading Our Minds, The Rise of Big Data Psychiatry. And I'll include a link to my publisher's website right here.
So, coming back to Mike, any, some of your parting thoughts on how this field is going to go forward?
Yeah, I think as Dr. Barron has alluded to, there has been a dearth of objective signals for mental health. And I think to get precision psychiatry, precision mental health, you're going to see a lot more of these signals and these instruments being developed. And we feel that voice is really the true vital sign and can provide you with multiple different vital signs, exactly for depression, anxiety, and for other conditions. And people should realize that, voice is going to be the way to assess people now for mental health in the future.
No, that's a terrific insight. Something truly is new that I did learn, and the use of voice. I think it's a great signal. So thank you so much for that insight. I know both of you are super busy, and we do appreciate you coming on this call and presenting your thoughts in the session. My time is actually up. I'm actually cutting into Stan. So I wanted to thank you both on behalf of the symposium organizers, and we look forward to welcoming you back at a future session.
Thank you so much.
Thank you very much for having me.